meet with Congress members and others to listen to them and to build relationships. And through that work, we've learned that the role of the federal government is huge in healthcare, especially through Medicare and Medicaid. And so those programs really have a huge impact, and they need, our participation and our help in them. And that's how we kind of came to the idea of an act that would create more prevention services. What does this say? An ounce of prevention is worth a pound of cure. And, all of you know that. And in the existing federal legislation now, the funds primarily provide for direct medical services. And too often, folks end up being, very ill. And of course, that costs more money, but illness could have been prevented had we been able to reach out to them. So if this bill passes, it would create a funding stream through the Social Security Administration for both Medicare and Medicaid. With Medicare, it would be automatic when it was passed. And then with Medicaid, states that wanted to do more prevention services would have a law to help them do that. So there's a possibility of, really great impact. And of course, when we talk about prevention services, and I'm sure you know this, that there's just so much going on in our communities with eligible folks that is kind of a chasm or a gap between their health needs and the services that they're eligible for. And as a result, many people get very sick and need more expensive services and don't get treatment. And so the idea of this is, and I can share this slide deck, is to create that funding stream for you all as CHWs who know the community, who have the relationships that can reach people and be able to serve them in all these prevention ideas, from helping with transportation to managing their caseload, to making sure they get screened for the proper tests, to working with the primary care physician to make sure that they're getting their appointments and being referred to specialists or whatever's needed in a prevention manner. And so it really just expands this whole idea of those who know the community best and can serve the community will have the funding, the permanent to do that. In many cases, and I know, some of the HQCAs in Idaho, reach out and do prevention and outreach services, but, many times it's just maybe on some private funds or temporarily, and the needs we think is great. And especially, in Idaho, where you have distance is such an issue, and you have many rural needs where people don't have the support in rural areas that you do in urban areas. So this all goes back to something called the social determinants of health. And I hope you may have heard about that. But in federal legalese, the Department of Human Services, Health and Human Services said that disease really often comes at a greater extent in communities that are impacted by stress and by individuals and families that have bad living conditions, not a good diet, few educational opportunities, maybe crime. All those social pieces impact people greatly, and they're more likely to get sick. So the social determinants of health, which here allows CHWs to identify those people and refer them to the services in the area that they may need so they can reduce that stress, and identify communities that are not being served, and making sure that folks are aware of what's available to them and can connect with them. So the social determinants of health are really something important to look at disease in a new way. And this is one of the first acts that really, if it's passed, will do that. The other piece that I think is so interesting is that we found in our communities that we serve that often CBOs or community-based organizations, federally qualified health centers, you know, you all in those groups are know your communities, are attached to the communities and can better serve them than some of the larger statewide organizations. And so the CBOs are really important, and they need more help. They need support on how they can receive funds from the federal government, how they can manage those funds. There are many barriers. For example, one most common is that if they do get federal funds, they only get paid after the service has been delivered. And if their budget is really tiny, then they can't afford to handle that cash flow. So this bill will get a path for direct funding for CBOs, and also give them the capacity and the training to learn how to work with federal programs and receive federal money, and have the capacity to do that. So if this passes, this will really be great for all of us as CHWs that are connected to our communities to be able to hopefully employ more. Finally, the costs for health spending is always an issue. And anytime that you pass a bill, it's like, oh, well, this is going to cost us. And obviously, we know that an ounce of prevention is worth a pound of cure, and that the more we can prevent disease, the better off our folks in our community are, but also it's cost effective for the government. And so there's some studies here, are a couple that show, like, for $1 spent, it saves $1.81. Another study was even greater ratio of that. And so when we educate people about this act, I think it's important we show that there's information that obviously it saves money and it's good for healthcare. And so that is it in a nutshell. You've got a big agenda today. My only ask is, if you think this is something that's needed in Idaho, if you can think of situations where this would help your work, you would be able to do more. Maybe your employment would be more stable. We would have more people that are eligible. We prevent disease. We'd love to hear from you. And I'll put my name in the chat and my address, and feel free to email me, and we'll be sure to follow up with you. So thank you, and I'll pass it.
Brooke. And Brooke, how do you say your last name so I don't mess it up? Ambrose?
Yes, it's Ambrose.
Okay, I feel like it's one that could be tricky. So, and she's coming from the Division of Public Health, Idaho Department of Health and Welfare. She is an MPH and public health professional with a passion for supporting underserved communities and advancing health equity. She has a background in systems analysis and innovation, and has worked extensively on initiatives specific to sexual violence prevention, adolescent health, health promotion, and injury and violence prevention. Her experience includes some collaboration projects with state health departments, as well as developing community-centered programs and applying trauma-informed approaches to create safe and supportive environments. She brings a deep commitment to providing tools and insights to community health professionals for their vital role of fostering healthier and more resilient communities. So we're excited to have her present. And at this time, Brooke, if you want to hop on and share your screen, I'll stop sharing mine. And then we'll turn the time over to Brooke.
All right, I will give the sharing the screen a shot here.
Yep, you're good.
All righty, are you all seeing my presentation?
Yes, it looks great.
Perfect. Okay, so to get going, I wanted to introduce you all to the sexual violence prevention team here at the Department of Health and Welfare. So over here is Heidi with her little guy, Ozzy. She is the program manager for the sexual violence prevention team. And as you can see, we are pretty small, but we are mighty. I am the other person on the team here. I'm a health program specialist, so I actually support this program and another program that's focused more on injury prevention. And then our funding statement as well, just wanted to mention that the project that we work on is funded through the CDC, a rape prevention education grant, and the contents of this presentation are solely the responsibility of the authors and do not necessarily represent the official views of the CDC nor the Department of Health and Human Services. All right. So I'm going to be doing a Mentimeter 2 to kick us off. So in the chat, I will put the menti.com link as well as the code that we will be using. But the first question that I am hoping you all will answer with me is, what do you hope to get out of this session today? So I'll give you all a minute or so to put in some responses, and I'll try and pull up that cool presentation like Ryan did. Ooh, awesome. It's all coming in all at once, it looks like. So on my screen, I'm hoping you're all seeing this too. It's showing prevention tools, screening, information, new content. Awesome. We will definitely be sharing some tools, so I'm excited to see that as one of the most common responses. Knowledge and resources will definitely be shared too. All right, awesome. Well, y'all can keep putting some answers in there if you would like to. We are going to move forward. Thank you for participating in that Wordle activity. And I am hopeful that today between the presentation, we're hoping to have some question and answer time at the end and access to having the online module that we will touch base on all or most of the expectations that you all have today. So with that, some of the learning objectives that I'm hoping will come across today are listed on the screen. So by the end of today, we hope that all will be leaving here with a better understanding of sexual violence, Idaho's data, and knowledge on what can happen to survivors. We will feel more comfortable communicating with survivors of sexual violence and will uplift the fact that knowledge is prevention, knowing that most folks here also have access to that health, the Sexual Violence Prevention Community Health Workers Learning module to further expand your understanding after today's session as well. And then before moving forward, I wanted to throw out there too, if you have questions at any point in time, please feel free to come off mute or throw them in the chat. I'm happy to kind of keep this more of a discussion if we would like to do it that way. But to ground us first in an understanding of sexual violence, which I want to say I might switch off between calling sexual violence, and referring to it as SV sometimes for short. So if you hear me say SV, I'm regarding sexual violence. So the CDC defines sexual violence as sexual activity when consent is not obtained or freely given. It impacts every community and affects people of all genders, sexual orientations, and ages. Anyone can experience or perpetuate sexual violence. So some other things that are important to note is that sexual violence can occur in person or through technology. So this includes things like sharing sexual pictures of somebody without their consent. Additionally, it is known that perpetrators of sexual violence are usually somebody that the survivor does know. So this can include folks like friends, former or current intimate partners, or neighbors, as well as other folks that people might know. And then I do have a link that I want to share in the chat really quick for the CDC's definition of sexual violence. All right. So next, I acknowledge this slide looks pretty dense and it can get pretty dense, but I thought it was really important to know the makeup of the environment that we're working within. So I wanted to highlight some national facts and statistics around sexual violence. So some information that highlights the fact that we know sexual violence is common includes that over half of women and almost 1 in 3 men have experienced sexual violence involving physical contact at some point during their lifetime. We also know that 1 in 4 women and about 26 men have experienced completed or attempted rape. I believe that's supposed to be 26%. I just left out the percentage sign on there. So that's where that 26 number comes from. And then we also know about 1 in 9 men were made to penetrate someone during his lifetime, and 1 in 3 women and about 1 in 9 men experienced sexual harassment in a public place. Some facts that inform us that sexual violence starts early includes that more than 4 in 5 female rape survivors reported that they were first raped before the age of 25, and almost half were first raped as a minor, so before the age of 18. While nearly 8 in 10 male rape survivors reported that they were made to penetrate somebody before the age of 25, and about 4 in 10 were made to penetrate as a minor. So keeping this in mind, we wanted to touch on and kind of bring back up the fact that perpetrators of sexual violence are often known by the survivor. So of the sexual abuse cases reported to law enforcement, 93% of the juvenile survivors knew their perpetrator. That's a very large amount. So I did want to highlight this graphic over here that is from RAIN, which is the Rape, Abuse, and Incest National Network. I will put a link to the article that this is from in the chat as well. But I think it just does a good job of showing that sexual violence really is often perpetrated by somebody that the survivor knows, highlighting the amount of acquaintances, the amount of current or former partners, a family member, that type of thing. I do think that article is pretty interesting as well if you wanted to check it out. And then the last point I wanted to highlight on here is that the majority of children and teen victims do know that they're perpetrator. So just keeping in mind the long-term effects that can have on a person and the long-term implications as well. All right, now getting a little bit more honed into Idaho, I wanted to talk about Idaho's data. So there are 3 main data sources that specifically look at sexual violence in Idaho. In the past, data on the prevalence of sexual violence in Idaho and its effect on victims has been limited. Recently, to data on incidents, but we've increased that a little bit recently. So our 3 main data sources are the Idaho Crime Victimization Survey, which has not been conducted since 2012 and leaves a gap in our knowledge around the prevalence of SV victimization in our state, just due to the fact that it hasn't been conducted in quite some time. However, since 2023, the Idaho Statistical Analysis Center, which is couched under the Idaho State Police Department, has examined performance data on federal grants for crime victim services, which includes SV or sexual violence victims. And then our third source of data is going to be the Behavior Risk Factor Surveillance System, or BRFIS data, which helps expand knowledge of sexual violence in Idaho by estimating the prevalence of sexual violence victimization through a population survey rather than relying on administrative data from law enforcement and victim services agencies. So the hope is that BRFIS will include more than just the counts of victims who come into contact with those agencies and give us a better picture of what this looks like in our state. So BRFIS does provide some new information on how sexual violence is related to a range of adverse health outcomes as well. So first, I wanted to show kind of a comparison of these 3 different data sets. So this top one you'll see is the BRFIS data. The middle one is the Crime Victimization Survey, and then, the bottom one's the Crime Victimization Survey. And this middle one is going to be the numbers reported by our providers of direct services for victims. So the number of Idaho adults who experienced sexual violence in the past 12 months listed here is estimated at 13,112 individuals, which is higher than the number who received victim services, which is 4,119 after being sexually assaulted or abused or reporting a sexual assault to law enforcement that same year. So that leaves a difference of 8,921 individuals, or 32% of survivors not having access to services. So that means that on top of that, there is even less reported sexual violence experiences to law enforcement, who only had the 685 reports. So connecting the report numbers back to the BRFIS data, that leaves almost 95% of sexual violence survivors in Idaho who do not report their experiences. So I do want to point out that since these are all separate data sources, this is not a direct assumption that we can make, but it's important to note and brings up the question, what factors might be contributing to this gap in our state? And then one last thing I wanted to note before moving on to the next page was that BRFIS is also administered over the phone, where we do have some research that shows alternative survey methods like self-reported surveys, like taking a survey online yourself or through the mail, can sometimes show significantly higher number of assaults than the self-reported numbers on our BRFIS surveys. So something to consider as well. There could potentially be a different volume of numbers in our state that are not going reported. So with all of this in mind, I do have another Menti question coming up for us. So it's going to be the same code. I'll re-put the link in the code in the chat. And this time we are going to be answering the question, why do survivors of sexual assault often not report to police? So again, I'll give you all a minute or two and I'll try and pull that screen up here for you. You can see the answers as they come in. Awesome. Okay, so we have stigma, shame, guilt, cultural implications. Yes, these are all spot on. Religious beliefs. Close that. They're embarrassed or ashamed, scared. Fearful of retribution, definitely not wanting the perpetrator to have legal consequences. Power of the perpetrator, something that I'm not going to be talking about today, but that is important to have an understanding of, is the cycle of power and control. So thank you for bringing up power, whoever put that comment in. All right, I'm going to move on, but you all feel free to keep putting answers in there. I just wanted to highlight a few reasons as well. So some were already mentioned, things like being ashamed or maybe being embarrassed or maybe even being afraid to tell the police or their friends or their family about the violence that occurred or that they experienced. They might also keep quiet because they've been threatened or they don't want anyone else to think differently of them because they don't know what they will think of them after they do divulge that information. There are a lot of different reasons why somebody might not want to report, and that is something that is up to them, but something that we can help people feel more comfortable in speaking with us about. All right, so before I get started on these next few slides, I wanted to note that all of this data that I'm about to share is coming specifically from the Idaho BRFIS data. So it was my assumption coming into this that the audience today is mainly community health workers coming from all across the state. So I did want to share some more statewide information. As a state's broken out into public health districts, this is normally how we display our data. So that's how I was able, the most granular level I was able to get it down to for you all today. But this image shows the lifetime prevalence of sexual violence estimated among adults by public health districts in Idaho. So although Health District 4 does have the highest percentage of adult Idahoans who've ever experienced sexual violence, it is important to note that there were no public health districts, including District 4, where the percentage was statistically significant from the statewide percentage, which is 13.6%. So this means that there is a relatively level rate of sexual violence experiences occurring across our state, that it doesn't discriminate on where you live or make too much of a variability in that way. So here we are looking at a chart that shows sexual violence rates based off of the residents' population type. So we're looking at frontier, rural, and urban. So as noted, about 12 of those, it was about 12% in the frontier and rural populations, while it was about 14% for folks living in the urban areas. But similarly to the prevalence data I just showed before, there was no significant statistical difference with the populations that were separated out between these three categories. So again, just reiterating that that means there is a relatively level rate of sexual violence experiences occurring throughout the different types of communities in our state as well. And then one more statewide map here, just highlighting the percentages of adult Idahoans who experienced childhood sexual abuse, which is estimated at 13.5% throughout the state. And once again, there was no statistical significance there was no statistical significance between any of the public health districts. So yet again, I feel like a broken record here, but I really do want to reinforce that that does mean that there's a relatively level state of sexual violence experiences occurring throughout the different communities in different areas in our state. So it's across the board. So on this slide are some of the demographics that show communities that are disproportionately impacted by sexual violence. So I wanted to highlight, and these are statistically significant, so it does matter here a little bit more. It's not the same experience across the board. So I wanted to highlight that the age group of 18 to 34 does experience sexual violence at a higher rate than some of the other age groups. Females experience sexual violence at a much higher rate than males do in our state, as well as folks who identify as part of the LGBTQ community. So that doesn't mean that there's something these communities are doing that puts them more at risk. That just means we know that folks who can be categorized in these areas with this experience might be at more of a risk for experiencing sexual violence. All right, I swear this is my last really dense chart for you all. But the 2021 BRFIS survey results also highlighted differences among sexual violence and non-sexual violence victims on a range of adverse health conditions. So I really do want to hit on this. These are some of the risk factors for sexual violence. So we wanted to show the difference in experiences of those that were experiencing sexual violence in our state and those that have not, to just highlight some of these risk and protective factors. So some of the outcomes included measures of overall physical and mental health and drug or alcohol use or misuse. Sexual violence victims were also nearly 2.5 times more likely than non-sexual violence victims to experience cost barriers to accessing medical care. And the impact of sexual violence extends beyond immediate trauma. So as victims are disproportionately impacted by a range of adverse health outcomes, both physically and mentally, compared to those who have never experienced sexual violence, this also means that they are at higher risk for experiencing other health issues as well. So those survivors who disproportionately face additional adverse childhood experiences or ACEs. I'm hoping most of you know what those are in this group. If not, I'm happy to answer questions on that later on as well. And then hitting on the national prevalence of sexual violence in people with disabilities. So while Idaho's BRFIS data, or most of Idaho's data, does not collect information on disabilities, we wanted to report on the national data about the prevalence of sexual violence in people with disabilities. So it is known nationally that people with disabilities are more than 3 times more likely than their non-disabled counterparts to experience serious violent crimes, such as rape or sexual assault. Compacting on this, having multiple disabilities can also increase a person's risk of rape and sexual assault. And again, I want to highlight here, when I'm saying somebody might be at risk, that doesn't mean it's something that they have done that puts them at risk. It just means that we've identified these factors as things that we know when people have these, they are at a higher likelihood or risk to potentially experience sexual violence due to the data that we've been sharing. And then the last piece I wanted to mention on this slide as well was that we do also know that children with mental health or intellectual disabilities are almost 5 times more likely than their non-disabled peers to experience sexual abuse. So highlighting that mental health or intellectual disabilities, and specifically in children. All right, we've been talking about some risk factors that can lead to sexual violence, but we also think it's really important to highlight some of the health problems that can result from sexual violence as well. So these might be some things for you all to be looking out for when you're in connecting with community members. Some long-term physical health problems would be things like having a disability, being permanently hurt from an attack, long-term infections, again, for example, something like HIV, short-term physical health problems, things like physical shock or diseases like an STI. Reproductive health problems can be things like getting pregnant, an unwanted pregnancy, again, unwanted STIs or HIV, difficulty having sexual intercourse. So sexual violence can increase the possibility that an individual acquires a disability, particularly a trauma-induced mental illness. And according to End Rape on Campus, which I will try and put a link for in the chat as well. You give me just a moment. According to End Rape on Campus, survivors can experience depression, post-traumatic stress disorders, and alcohol or other drug use at rates higher than non-survivors. Survivors can also experience physical, psychosomatic, and behavioral effects. This is critical to ensure that these health conditions are treated seriously so that the survivor can access the treatments and support that they need. And in ensuring this access and the seriousness of addressing these issues, it also strengthens that relationship that the community member has with the health system and the trust that they have with the reporting system as well. So some immediate impacts of sexual violence. Another link to share, give me just a moment. I know, so many links today. So that is a link to a resource on the impact of sexual violence from NSVRC, or the National Sexual Violence Resource Center. In addition to that resource, I wanted to highlight the graphic on this slide as well, again, identifying some of the direct impacts survivors experience. It's also important to note that sexual violence is costly. So recent estimates put the lifetime cost of rape at about $122,461 per a survivor. So this includes things like medical care, lost productivity from work, and criminal justice costs, all on top of these other immediate impacts such as injury, safety, becoming pregnant, being fearful, having a sexually transmitted infection. The list goes on, as we know, unfortunately. So we're going to jump back over to Menti for a little bit to answer a few more questions. So we're going to use the same steps to get connected to Menti again, and I will throw the link and the code again in the chat just in case folks still need that. And the question we are going to be answering first is thinking about the number of people estimated in the state of Idaho to have experienced sexual assault, which is at about a little over 13.5%, and the physical and mental impacts that sexual violence can have on an individual. How likely do you think it is that you will work with a survivor of sexual assault in your role as a community health worker? I had a feeling this would be how this chart turned out, honestly. So I'm not too shocked to see their responses, but it does look like most folks think that it is likely that they will work with a survivor of sexual assault in their time as a community health worker. I have one more question before we get back into the presentation. And that is, what is the role of a community health worker in supporting survivors of sexual violence? So I know that one's a little bit more of a loaded question, so I'll give you some more time to answer. I'm sorry, these QR codes are cutting off the question. I'm gonna take the QR code away. Yes, these are all great. Listening, definitely a big one. Making a safe space, support, resources, trauma-informed care, yes. Non-judgmental, referrals. You guys are amazing. I don't even know why I need to ask you these questions. This is great. Wow, this is really awesome. So I feel like I don't even need to show you my next slide here, because I was just gonna highlight on some of the needs that you all mentioned. A community health worker would support in a sexual assault victim. So I'll just reiterate really quick the things that I have listed here. To be believed, to be listened to, a non-judgmental response, physical and emotional safety considered first, support, not to be blamed, to be in control of what happens next, and having information, knowing what resources are available to them and respecting their privacy. So something that is missing in this image, but is of most importance, is to start again with the belief. That's the very first place that we want to start. If someone's divulging this type of sensitive information to you, we always believe the survivor. That is definitely part of a trauma-informed response. So just wanted to kind of bring that up to the forefront as well. We're not here to question the survivor, we're here to support the survivor. All right, and then hitting on some ways to respond. So first, starting with empathy, listen and affirm without judgment. Assure them that they're not to blame for the abuse and that you are available to them. Respond empathetically, because when they feel validated, they are more likely to open up, and we can say things along the lines of, that must be hard for you, and that sounds so hard or so scary. Let them know that you're always available for further conversations, and that if they don't bring it up again, you can. And then something else that's important to note is ask, don't tell. So many of us, especially those of us working in community health, want to solve problems, and we want to solve problems for others. We want to jump in with this is what you're going to do, or this is what you should do. But it's something that we need to kind of reel ourselves back in with. And I know I can relate to this myself, being in the social services industry, having a tendency to want to rescue people. But it's important to give your client the agency to help themselves. As I was kind of mentioning before, not having that power and control in your life is very off-putting. So to be able to get that back is huge for a survivor. Sexual violence leaves survivors feeling powerless, so we do need to remind them that they have a power over their own lives. Something else we can do is direct them to their local domestic violence agency. Make sure you know the resources in your area. That's also super helpful. And then asking the survivor about their support base and encouraging them to reach out to their local support agency or a counseling service. And then last, the one thing I wanted to make sure to follow up on is to stay connected with that person, to not just help them in that one-off moment and not follow up again. It really is important for survivors to have that network and support and staying connected and helping them navigate throughout the process, since this is a very complex issue and experience to have. There are multiple systems that come into play if folks do choose to report. So having someone be consistent with them throughout that really does help. All right, so we do have another Menti poll. Looks like that's still the most recent chat I sent. But I'm going to be asking you all now, how can community health workers create a supportive environment for someone who may have experienced sexual violence? Awesome. So we have a few coming up in here. Some suggestions were to make sure they feel like they are in a safe space, to meet the individual where they are at and help them with what they want help with in that moment. Super important. Affirming their experiences by being an active listener, affirm and connect to resources, support. Yes, okay, awesome. Listening, yes, these are all great. So some things I wanted to highlight as well that community health workers can do to help victims find the appropriate medical, psychosocial, and other healthcare services. For example, could be if a victim was unaware of the risk of a sexually transmitted infection, a community health worker can refer them to a medical service provider that can test for such infections. Similarly, community health workers can help victims who wish to pursue legal redress by referring them to a doctor or ER to be examined for potential evidence, or to a domestic violence and sexual assault agency who are experts in offering survivor support and walking them through these options. Community health workers can also refer victims to legal aid groups who can advise them on the possible benefits and ramifications, as well as safety precautions if they do decide to take their case to court. All right, and then something else that I wanted to highlight as a really great option for supporting survivors is creating a safety plan. So I'm gonna put another link in the chat if I can. I need to find the link, here we go. Okay, so this link is a really awesome tool from NDVH that helps you create a personal safety plan, and you can use it with a client in real time as well. But to go over some of the steps of the safety plan, they might seem quote unquote obvious, but it can be hard to think clearly or make logical decisions during moments of crisis or trauma. So creating a plan and having a plan laid out in advance can help your clients protect themselves and others. Say, for example, if a child was involved in the situation in high stress situations. So each safety plan is unique to each individual client and their situation. And it's especially important to have one of these if a survivor or victim is living with their abuser. So some important elements to include are creating a code word that you can use with friends or family. That means call for help, copying or storing important documents safely inside or outside of the home, backing into your driveway and keeping your vehicle fueled up so you're ready to go, having a go bag hidden and an extra set of car keys, safely documenting the abuse, practicing leaving the home in a crisis, and identifying safe places for the survivor and their children to go. So again, I think I already threw that link in the chat for the NDVH Interactive Safety Planning resource. I think that's super useful and really great in just helping people think through realistically what steps can be taken. All right, more links. Finding local resources. I think this is super, super important to touch on with you all, given the work that you're doing in our communities. I lost my link. I'm sorry about that. But the link is to this resource that is on the page here. This resource was created by the Idaho Council on Domestic Violence and Victims Assistance and is Idaho specific. I'm having the hardest time with this link here. But these groups are all experts in things like safety planning and have connections to many other resources for survivors of abuse. I will do my best to get that up in the chat for you all, but if not, I will get it sent out to you all after our meeting today too.
Did that work?
Oh, thank you, Sarah. Yes. Perfect. Okay. And then building connections to resources. So as a community health worker, it is important to not only know the name or location of your local domestic violence or sexual assault service agency or shelter, but to be a connector or resource broker for that organization as well. So letting the person you're working with or your client know what they can expect if they do call or reach out to their local DV or SA agency can really help in making them feel more comfortable in making that step and calling their domestic violence or sexual assault agency. So our recommendation for community health workers is to visit the agency, your local agency, and to meet with an advocate. Or if that's out of reach for you, another option would be giving them a call and just having a conversation to really gain a better understanding of the services that they provide and what the process looks like if someone were to call and disclose a sexual assault. So with that, I'm going to ask yet another Menti question for you all. Thank you, Ryan, for putting that in Spanish too. So this last Menti question that we have today is, what are some other questions that you all think would be helpful for you to ask the person that you're working, excuse me, this is worded weird, I could have said this better, but what are some other questions that would be helpful for you to ask the DVSA organization so that you could then give the person or your client more information? And I'll give you all some examples too. So some things that come to mind for me are questions like, what kind of accessibility offerings do they have? Do they have a crisis hotline, or is it open only during certain hours of the day? Do they have a text line if the client's not comfortable with calling? Things along those lines. So I'll give you all a minute to have your ideas put out there. Are you safe now? That's definitely a great question. What is the cost? Yes, I know that's definitely a question we hear a lot. Are you safe? Do you have support?
I put my answer in the chat. It was still asking me from the previous question, so I just put it in the chat.
Oh, I'm sorry about that. Thank you for putting it in the chat, Sonia. Sonia also added to the question, do you have a plan? So they might already have a safety plan in place too. Is it a safe space? What services do you provide? How do you best support the survivor or victim? Yeah, these are all really great questions, and questions that the answers that you get might spark more questions for as well, which is always the great part of being able to have that working relationship with your local DV or SA agency as well. All right. So we just wanted to hit a little bit more too on community health workers as community change agents, which I know you're all aware you are a community change agent. But we just wanted to highlight that as a community health worker, you can be a role model in your community to help change the negative social norms and attitudes that can make it hard for survivors to discuss sexual violence and access health services if that is what they want to do. You can build that trust with your community by being competent and a reliable source of care. And as a community health worker, you are a trained navigator already in complex systems, and you know the importance of treating everyone with respect and upholding your clients to have their own agency. And these are just things we wanted to reiterate that are all important factors, and also creating safe spaces for survivors of sexual assault to feel trust in creating a culture where disrespect and violence is not tolerated. All right, and then I did want to highlight really quick the community health workers sexual violence prevention module. I had a little bit of a hard time doing my best to not include all of the information that was included in this module. So it is very different information is included in the module. So I really do encourage you to go check that out because this is just supplemental information to that. It does not, we did not cover everything here today in the slightest, but our module does have 4 smaller modules that it's broken out into. It starts with the introduction, just kind of going over, again, like we just hit on today, the role of community health workers, definition, data, but then we really go into building community awareness, trauma-informed responding and safety, and self and community care. As we kind of touched on with the icebreaker this, I want to say this morning, we're already in the afternoon, taking care of yourself as a community health worker is really, really important in this work as well. If you're going to be able to continue to show up for survivors, you're going to need to be able to take care of yourself as well. So we definitely wanted to hit on that too. And then really quickly, how you can find our module. I'm sure most of you are familiar with this, but I just wanted to share a few steps. So from the main Community Health Worker Training Academy landing page, you would click on the Community Health Worker add-on health modules. And then you're going to click on this little link right here as well. When you get to the Community Health Worker add-on health modules page, and that will take you to a very long list of really awesome modules that are in alphabetical order. And since they're in alphabetical order, you are going to scroll to the bottom of that page to find sexual violence prevention, which starts with an S. And this is going to be where you would click to get into our module. And this is what it looks like at the start. All right, but with that, I feel like I've been talking so much today, and I wanted to make sure we have some time for questions. I'm not sure how much time we have left because I have done so much talking, but I do want to turn it back over to you all and see if there's any questions that I can help answer that might have been brought up today.
Yeah, we have just over like 5 to 7 minutes for questions, so that's perfect.
Awesome. I always like letting folks know I am a fan of awkward silences, so I can let this go on for a while. But if there aren't questions, something else that I thought would be helpful for us to discuss is if folks want to bring if you're comfortable bringing up situations or potentially experiences that might have happened or that you're anticipating could happen, and that we could kind of talk through as a group how we might navigate that situation if there are no questions, that's another option.
Being in my age group, I find it very interesting that there is a lot of women my age and older that have family history of abuse, sexual abuse, and how it's all put under the rug. But you know, when you're that age, it's really hard because they can go and talk and get help, but it's very you just have that compassion within just knowing, you know how they were made to just deal with it and let it happen. They didn't have, it wasn't out there when we were little.
Definitely, compassion and empathy or sympathy are very, very big in any aspect of sexual violence prevention type of work. But I imagine especially being hands-on, directly working with that community member. And something else that you kind of brought up that's really important to consider that folks did bring up throughout the questions today as well is that cultural aspect. That could be an ethnic culture, but that could also be an age group cultural kind of setting. It can be an Idaho cultural setting, or it can be a micro Idaho community cultural setting. Just really having a good pulse on what those social norms are in your area, I think really help navigate those difficult conversations sometimes. All right, well, I can pass it back over to you all. I'll put my contact information in the chat. I'll also share the program manager for the sexual violence prevention programs email as well. If any other questions come up or you just didn't feel comfortable asking in a big setting like this, I totally get that. Please feel free to reach out to us. We're happy to connect you to other resources and organizations as well.
Thank you so much, Brooke. And just like as a follow-up with your contact information, we'll share, if it's okay, we'll share your slides and all the links, all of them already, you sent them to me. So I'll make sure that when we send out our email tomorrow with the recording of this educational session, that will include all of those resources for you to easily access through your email. So if anyone, those are more than welcome to be forwarded onto your teams, those that you're working with that could also benefit from them. So yeah, thank you so much, Brooke. It's such an important topic where community health workers really are the front line, with their communities, and really having that cultural awareness of how their communities, like you said, getting a read on the pulse of a community. Our community health workers are incredible at approaching things with the knowledge of their community at the forefront. So, Ryan, I know we typically do an evaluation at the end of these. We're having a little technical difficulty, so we'll probably send that evaluation link out tomorrow along with some of these resources. So if you can watch for that in your emails, we would appreciate your guys' feedback as we use those evaluations to, select future topics, as well as make sure that you're getting what you need out of the educational sessions. So, okay, any last statements from Brooke, Ryan, anyone else? All right. Well, we are right at 3:30, so we'll wrap up our meeting today. Thank you so much for joining.
Thank you guys so much. Thanks for sharing, Brooke.
And make sure you take some time for self-care today if you can. I know sexual violence can be a heavy or triggering topic, so make sure that you take some time to take care of yourself. And we appreciate your participation today.
Thank you.
Thanks.
Thank you very much. Appreciate it. Bye-bye.
See you next